This is Michael Altos recording Basic Principles of Clinical Pharmacology based on Barish Chapter 7. This is Part 3. We've spent a lot of time talking about pharmacokinetics, which is what the body does to the drug. And actually, when we give a drug, we're not usually thinking about what the body does to the drug. We're busy thinking about what the drug does to the body. And so it's time for us to turn our attention to pharmacodynamics. First, we need to define a few terms. So we have words like the ED50, which is the effective dose for 50% of the population. This is the dose of drug that you need to give to get a certain effect in 50% of the population. This is sort of like MAC for drugs, for injected drugs or oral drugs. We also have a lethal dose at 50%. This is the dose required to cause death in 50% of the population. And by comparing these two doses, we can get an idea of the therapeutic index, which is a measure of safety. How safe is the drug that we're giving? If the LD50 is very close to the ED50, well, that's not a very safe drug. But if the LD50 is 100 times higher than the ED50, then we have quite a margin of safety before we go from therapeutic to toxic dosing. This simulation here demonstrates the idea of a therapeutic index. This is a dose-response curve, which we'll go over in more detail in just a moment. But here we have a drug's desired effect, let's say analgesia, and its adverse effect, which might be, let's say, apnea. So as we give a certain dose of drug, more and more people get analgesia, until finally 100% of people have analgesia. But also, as we give more and more drugs, certain numbers of people start to have apnea. And the question is, what's the gap between these two? Well, a drug with a high therapeutic index, the chances of getting apnea may be very, very low, whereas your chances of getting analgesia are very high. But as the therapeutic index becomes smaller and smaller, and the drug becomes less and less safe, so now here I am giving a drug with a relatively good chance of getting analgesia, but also a pretty good chance of getting apnea. We need to talk about the receptor model, which is simply the idea that drugs bind to receptors. The drugs are agonists. An agonist binds and produces an effect. And here we have our agonist, drug X, binding to receptor R. Fentanyl binds to the mu receptor, for example, and that causes an effect. There's a lot of redundancy in the biological systems, which means you have more receptors than you need. And you don't need to get all receptors bound in order to get the maximum effect. Usually, you can get your maximum effect at far below maximum binding. So for example, in your neuromuscular junction, you only need about 25% of your receptors bound by acetylcholine in order to have enough strength. In fact, that's why people will always tell you you need to block more than 75% of the receptors in order to get clinical weakness. That's because of redundancy. Remember that there isn't just one receptor in the human body. There are billions of receptors, and each one has an agonist binding to it and unbinding it rapidly in equilibrium, back and forth. And as the process shifts more towards bound, we see more of a clinical effect. And as the process shifts more towards unbound, even though it's going back and forth rapidly, we see less of a clinical effect. Now let's look at dose-response curves. This curve, let's just start with curve A. We are seeing effect, or response, as a function of dose. And as we give more drug, we see more effect. Efficacy describes the maximum effect a drug can cause. So for drug A, there's a maximum effect, and you can't get any more effect than that no matter how much drug you give. Potency describes the amount of effect you get for a given dose of drug. It's effect per milligram, for example. So if we look at drug A versus drug B, we see that drug A achieves an effect at a much lower dose than drug B requires to get the same effect. Since drug B needs more drug, we say it's not as potent, and drug A is more potent. But if we compare drugs A and C, we see that there is an issue of potency, where at this point I get more of a response from drug A than drug C for the same dose. But more notably, I see a difference in efficacy, where drug A is able to achieve a higher effect, and it looks like drug C, although it hasn't been cut off, but I would imagine drug C has leveled out, and no matter how much drug I give, it will never have as much efficacy as drug A. Tolerance is just talking about diminished response due to chronic exposure. And tolerance can happen because of cellular tolerance, which is like adaptation. It can happen if you have enzyme induction, which could be due to other drugs being administered, and that's really just a change in metabolism, and many, many other mechanisms. Tachyphylaxis is a term that just describes acute tolerance after only a few doses. So when you're on your 4th or 5th dose of ephedrine in the operating room, you may see less of an effect, and that could be due to tachyphylaxis. A few more comments about the receptor model. We've talked about agonists. How about an antagonist? Antagonists bind to the same receptor, but they either block or dampen the effect that the agonist was causing. There are many different kinds of antagonists, and for the purposes of this lecture, I'm just going to focus on 2 simple examples. One is a competitive agonist, and we've called that Y over here. And we see Y is trying to bind to the same site that X did. So for example, if X is fentanyl, Y could be naloxone or Narcan. And when Y binds to the receptor, there's no effect. But we can see that X and Y can sort of fight for the ability to bind to this receptor. And once again, we're in equilibrium. So at every moment, Y is bound and unbound, and X could sneak in at any time and bring the equation towards an effect instead. And actually, the more X I give, the increasing doses of agonist can overcome the effect of this antagonist. So what we're really seeing is that competitive antagonists decrease the potency of an agonist, which means you'll need more agonist to get the same effect, but not efficacy. If I give enough agonist, eventually I'll have my effect. If I give enough fentanyl, I can not only overcome the Narcan, but I can get the full effect of fentanyl eventually. On the other hand, a non-competitive antagonist, we'll call that Z, it also binds to the receptor, but either it binds irreversibly or it binds at some other binding site, which causes a conformational change in the receptor. Whatever it is, it can't be completely overcome by giving more and more agonist. And so these are drugs that reduce both potency and efficacy. Let's quickly see this in the simulation. So here we have a dose-response curve for a drug. And here's the effective concentration for 50% of the population. Now let's add a competitive antagonist. So if we have fentanyl, let's add some Narcan. So what has that done to the curve? Well, I can give enough fentanyl to overcome Narcan. In fact, if I give enough fentanyl, I can still achieve the same efficacy, the same maximum effect of fentanyl. But I'm going to need a lot more fentanyl in order to do that. So that's called changing the potency of fentanyl, which is what we see with competitive inhibition or competitive antagonism. Now let's take that away and look instead at a non-competitive antagonist. Now what that drug has done is 2 things. First of all, we can see for a given concentration, for a given dose, I get less effect than I did when the non-competitive antagonist was absent. But not only that, but my curve levels off at a much lower effect. And so we can see that with the non-competitive antagonist, we get not only a change in potency, but a change in efficacy as well. Remember, we have partial agonists, which are drugs that bind like an agonist, but they don't produce as much of a response as a full agonist. So these are drugs that have less efficacy than a full agonist. And in fact, they could fight with the full agonist. They could cause competitive inhibition and prevent a full response. And codeine and oxycodone are examples of partial agonists. Remember once again that these drugs can bind reversibly or irreversibly. If you have any questions, take a moment to jot them down so we can discuss them in class, or earlier if you want to find me. Next, we're going to talk about drug interactions. First, there are pharmacodynamic interactions. There are direct interactions like fentanyl and Narcan, fentanyl and its antagonist, or partial agonists like we just discussed a moment ago, like fentanyl and codeine, or even mixed agonist antagonists like fentanyl and nubane, midazolam and flumazenil. A lot of drug reversal is due to direct pharmacodynamic interactions. There are also some indirect interactions. So for example, when we reverse neuromuscular blockade, we don't give a drug that fights against vecuronium. Rather, we give a drug that causes an increase in levels of acetylcholine, and then it goes ahead and fights with the vecuronium. So that's more of an indirect mechanism. And finally, we have synergistic interactions. The most classic example is opioids and benzodiazepines, which together can make people a lot more sleepy and sedated and apneic than either of them does alone. There are also pharmacokinetic interactions, and these are interactions that occur at every step of the pharmacokinetic pathway. So for example, if you have a drug that changes absorption due to pH or blood flow, a drug that changes distribution, again by changing blood flow or cardiac output, drugs that change metabolism by changing hepatic blood flow or having an impact on enzyme activity. And it's good for you to be aware of drugs that are inducers and inhibitors of hepatic metabolism, because these drugs can have an effect on the way we conduct our anesthetics. And finally, we can have what they call pharmaceutical interactions. And these are things like precipitation in the IV tubing, or degradation of volatile anesthetic in soda lime, or sugammadex being given and it chelates neuromuscular blocking drugs. These are all different pharmaceutical interactions. We will stop the recording here. Again, if you have questions, please let me know or bring them to class, and I'm happy to go over them in more detail.